Assalamu alaikum. Good morning. Today we'll be talking about infective endocarditis, and as usual, we'll talk in terms of case scenarios, 2-3 case scenarios in the beginning, and then we'll be talking about the pathophysiology. This is our first case. He's a 24-year-old male who is reported in the outpatient department with 6-month history of being unwell. Fever, joint pain, he had lost about 5 kg of weight, has progressively increasing dyspnea, which has now progressed to grade 3. He does complain of a mild non-productive cough. He also received antipyretics, NSAIDs, antibiotics from his local general practitioner. On examination, he is a thin, lean, pale-looking man. He weighs around 49 kg, pulse of 100 beats per minute, blood pressure of 115/70. His JVP is raised 6 cm above the sternal angle at an angle of 45 with a prominent A wave. He does have finger clubbing and marked pedal edema. His orodental hygiene is poor, and has 2 of his teeth are missing. On systemic examination, his apex beat is located in the 6th left intercostal space. It's outside mid-clavicular line and is heaving. There is a systolic thrill at the left sternum border. He has grade 6 pan-systolic murmur, which is harsh in its quality, and it is radiating to the axilla. There are bilateral basal crepitations auscultated at the lung bases. His spleen is palpable about 2 fingers below the costal margin, and his optic fundi show multiple hemorrhages. So with this description, we have to have some differential diagnosis in our mind. And that differential diagnosis should be, can somebody point out the diagnosis? Now, our provisional diagnosis, looking at the history and physical examination and the auscultatory and palpatory finding in the precordium, does suggest that this patient appears to have rheumatic heart disease. Now, the sequence in which we usually describe the cardiovascular diagnosis is what is etiology. It looks like to be the auscultatory finding of a pan-systolic murmur radiating to axilla points that the valve at fault is mitral and it is regurgitant, so mitral regurgitation. There is evidence of biventricular failure. He has raised jugular venous pressure suggesting a right heart failure. He has bilateral basal crepitations and a third sound suggesting left heart failure. And of course, he is at the moment in functional class 3 as far as his dyspnea is concerned. But the most important thing is that the features suggestive of subacute bacterial endocarditis. His fever, malaise, ill health, loss of weight, some non-specific joint pains, they all suggest a possible endocarditis. Now we have another case. Now this time is a 24-year-old male. He is a known IV drug abuser, and he has presented with a history of high-grade fever, which is associated with rigors. He also complains of shortness of breath for the last 7 days. Now here the history is a bit short. He is another important thing is that he is IV drug abuser. An examination of this patient is markedly pale. His cardiac apex is located in the 5th left intercostal space in the mid-clavicular line, which means that it is within normal limits. There is a grade 3 pan-systolic murmur at left lower sternal border. It is high-pitched, it is blowing in character, and it is loud during inspiration. Now this murmur is more at maximal at the lower sternal border, and it is maximum best heard during inspiration. Now, can we make off again, as we did in the previous case, what is the likely origin of that murmur and why this young man is having this febrile illness along with it? Now, differential diagnosis in this gentleman who has presented with a short history of around 7 to 8 days of a febrile illness, but with the worsening dyspnea. Again, we can think of infective endocarditis, but which valve possibly is involved? We can think of HIV or AIDS because of his indulging into IV drug abuse, and is likely to have shared the needles and may likely to have infective immunocompromisation on HIV. A short history of 7 days enteric fever can also be discussed or considered. Not unlikely for malaria. It can be a lower respiratory infection. So we have put out the differential diagnosis in an order which we suspect, and the valve involved appears to be tricuspid valve this time. We have another case scenario. This is a middle-aged man. He's chronic alcoholic, he's been smoker. His main complaint has been palpitation and shortness of breath. But on the background of that, he received an intragluteal injection where an abscess was formed, and he has been having fever because of that for last 1 month and has been on various antibiotic from a local practitioner. During the course of this illness, he developed right-sided weakness, which was on examination found to be uncrossed hemiplegia. There was also a gangrene formation of the left lower foot or toes, and that has also developed in the last 1 month or so. On examination, his pulse was a classical collapsing pulse or water hammer pulse. There was wide pulse pressure. There were absent left posterior tibial and dorsalis pedis artery pulsations. And he had right hemiparesis of upper motor neuron type with an upgoing plantar and hyperreflexia. There was splenomegaly, but his fundus was normal and there was no skin or joint involvement seen. Now, in this case, from the description, we can think that this gentleman possibly has aortic valve malfunction, most likely in the form of say aortic regurgitation, because he has a water hammer pulse. Differential diagnosis in this gentleman would be again infective endocarditis, but possibly he is showering emboli. He is showering emboli to his carotid circulation. He is also showering emboli to his peripheral vessels, which has been a reason for his gangrene of the toes. Atrial myxomas can also have a picture like that. They can present with fever. They can present with say embolization to distal parts, to both peripheral and carotid circulation. Sometime a ruptured atheroma in the aorta or other in the carotid can lead on to possibly from aorta. It is likely to go to both circulation to the carotid as well as to the leg vessels. Vasculitis can have a picture like this, where you may have say involvement of the peripheral as well as the central or carotid circulation vessels. Hypercoagulable states like protein C, deficiency, polycythemia, hypercoagulable state can present with simultaneous gangrene as well as a stroke. A sepsis can do that. A sickle cell trait can do that. When you have multiple site involvements. With this background, I hope that you can recognize this. This is building inside Lawrence Garden or Bagajna, nowadays we call it. It is Qaid-e-Azam Library, and previously it used to be Montgomery Hall. Now, in all these cases we discussed, we have found that the person has either some an underlying known cardiac lesion, or may not be, or he was in the second case was an drug abuser, The third case was an elderly or middle-aged person with the widespread atherosclerosis, and the first one, the young person, possibly from clinical examination, tend to have uh, say mitral regurgitation. Now, the one thing which we had in common was a febrile illness, a worsening of cardiac symptoms in the form of breathlessness, dyspnea, palpitation, and along with that, uh, say, malaise and ill health. Now, this all points towards infective endocarditis. What is infective endocarditis? Now, infective endocarditis is a microbial infection of the heart valves or the lining of the cardiac chambers, and this microbial infection, uh, when it involves the endocardium, or particularly the endocardium wrapped around the valves, is more likely to have this picture, and this is called infective endocarditis. By microbial, we mean that it can be bacteria, it can be fungi, it can be rickettsia, it can be many small organisms, or uh, say microorganisms. This infective endocarditis can be defined based on the location, like we made calls in terms of left side infective endocarditis, or we may call it as when it happens on the normal valves of the patient, it is called native valve infective endocarditis, and when it happens on the uh, say prosthetic valves or replaced valves in patients who had had valvular surgeries or valvular replacements. So it can then be called as prosthetic valve endocarditis. Again, the prosthetic valve endocarditis, when it happens within 1 year of replacement of the valve or the surgery, it is called early prosthetic valve infective endocarditis. But when it happens more than 1 year after the surgery has been done, it is usually called late infective valve endocarditis or prosthetic valve endocarditis. It can involve the right side of the chambers, right side chambers of the heart, and then it is usually labeled as infective endocarditis of right side. And sometime it may be related to devices. Nowadays, uh, many a patient do have insertion of pacemakers, they have insertion of implantable cardiac defibrillators, and these may also provide a nidus for formation of infective endocarditis, and this is again one entity which we should be knowing. Sometimes we do describe it, whether it is how the infection might have been acquired by the patient or the individual. So sometimes it may be in hospital setting, healthcare associated, say infective endocarditis, or patient is in hospitalized. These infection is usually called nosocomial infection, and sometimes it may be a non-nosocomial. But sometimes the patient is having it from community, and it is community acquired infective endocarditis. And as one of our patient had, it can be intravenous drug abuse infective endocarditis. There has to be some predisposing factors to develop microbial infection of the endothelium, and the most likely possibility of as a predisposing factor is rheumatic heart disease. The mitral and aortic valve are more commonly involved, and particularly the mitral regurgitation or mitral incompetent valve are more likely to have endocarditis. We'll talk about the reasons. Aortic valve, both stenotic or regurgitant, either because of rheumatic process and sometimes maybe because of even degenerative old age process, can be involved. Congenital heart lesions like ventral septal defect, patent ductus arteriosus, and coarctation of aorta are again likely to have provide a nidus for the lodging of bacteria and formation, say, starting up the process of ventricular this bacterial endocarditis. And as we already described, prosthetic valves are likely to have this involvement. Now, how it happens? To have an endocarditis, you have to have some sort of a nidus or some sort of say focus of where this infection can start. So the initiating event in infective endocarditis is colonization of the valve by bacteria, and this happens during a process of bacteremia. So anything, any intervention, any procedures which leads on to bacteria gaining access to blood through, say, maybe from the oral cavity, maybe an IV drugs, or maybe a septic wound. And when they gain access into the circulation, into the blood, it is called bacteremia. Now, transient bacteremia can occur in, say, when you get a dental treatment or a prostate infection, or you get urological intervention like informed catheterization, or sometimes some gastrointestinal diagnostic procedures. Right? It is less common during upper GI or gynecological procedure, though there is a high incidence. So you have an underlying valve already being structurally malfunction, either because of rheumatic process or because of a degeneration, or there is a implanted valve, and on top of that the patient develops bacteremia. Right? Now this then leads to the initial, there has to be endothelial damage, and this bacteria then initiate inflammatory process. There is platelet and fibrin thrombi formed, and then microorganisms adhere to that, and they keep on forming layer over layer after layer of this say microorganisms plus platelet fibrin, and it is this continuous layering of these deposits of fibrin, platelet, and microorganism, which are called vegetations, where they grow onto those damaged surfaces or damaged valves. So infection usually occurs along the edges of the heart valves. Right side infection, of course, is more common in IV drug abusers, but the left side infection is more common as a result of a previously damaged heart valves. Now, the endothelial damage by infection then leads to deposition of platelet and fibrin, which are colonized by blood-borne organisms, and this mass, which is composed of fibrin, platelets, and infective organisms, this is what is called vegetation. Vegetations can be very small, and they may be large, and the inflammatory process set in there. This leads on to further ongoing damage to that valves, and this valve damage may further get complicated, or may get further say if there's incompetent, it may be more become more and more incompetent, and further malfunction starts taking place. Which organisms usually can cause this bacteremia or are responsible for endocarditis? The gram-positive organisms are the more common one. The list includes, in our part of the world, it still is Staphylococcal viridans, whereas in the West, it is more commonly the Staph aureus, which is right. Staphylococcus albus and Enterococcus faecalis are also responsible for causing endocarditis. There's a long list of gram-negative organisms which can cause, like Brucella, Coxella, Chlamydia, Mycoplasma, Legionella, Histoplasma. They all can be caused. There's a Hayek group of organisms which includes these very organisms. They can possibly reason, and not to forget that the fungi can also lead on to formation of vegetations and lead on to endocarditis, in particularly in immunocompromised individuals and those who are in chemotherapies. Sometimes there may not be any organism grown on culture in these individuals, and then we think of a typical thing like Brucella or Q fever, Coxella brunti, Chlamydia, Mycoplasma. Sometimes Legionella is slow growing, it does not grow, histoplasmosis. And not to forget, sometimes you may have endocarditis, which may not be because of bacteremia, but because of the inflammatory products, like in patients with the systemic lupus erythematosus. This type of endocarditis is then labeled as Libman-Sack endocarditis. When your natural own valves develop endocarditis, it is mostly because of streptococci or Staphylococcus aureus or hypercarditism or enterococci. And gram-negative organisms like fungi account for a very, very small percentage of endocarditis causing organisms. But in IV drug abusers, the scenario is different. There, these patients usually use unsterilized syringes. There are staphylococci lying on the skin surface, and with each injection, this is Staph aureus, which gain access into it, and 80 to 90% of the patient of IV drug abuse usually get endocarditis because of the Staph aureus. Enterococci and streptococci may also be responsible, but gram-negative bacilli are unusual organisms in such situations, and they may be less likely or less commonly found in IV drug abusers. The prostatic valve endocarditis again has a different, say, bacterial spectrum. As we already said, early infective endocarditis, which is occurring within 2 months of replacement valve implantation, is usually Staphylococcus. It can be both coagulase positive or negative, and sometimes gram-negative or fungi can also be found. But in late prostatic valve endocarditis, the infection is usually streptococcal, like in other native valve endocarditis. And it may be both again. Sometime coagulase negative staphylococci still can be responsible for many of the patients who develop prostatic valve endocarditis. From the time of occurrence, again, it can also be labeled as most of the time it is subacute course, which means that the process starts and slowly and gradually patient become febrile, malaise, ill health, weightless, and that's why it's called as a subacute endocarditis. The course is usually over months. Another reason for it being subacute is that the organisms, their virulence or their ability to invade and cause damage is less, and that's why it takes a longer time to manifest, and that's why the viridans, enterococci, or gram-negative organism or fungi usually cause subacute endocarditis. But sometimes it can be a very, very acute or rapid one, and that then depends upon, again, the bacteria like Staph aureus. It is more likely to cause say acute or rapid onset, or it can develop within weeks or days. To diagnose endocarditis, you have to have a certain criteria which is called as Duke's criteria. Now, Duke's criteria comprises, like we have Jones criteria for rheumatic fever. This Duke's criteria again has major criteria and then minor criteria. By major, we mean that if these patients whom we suspect endocarditis and we suspect that there is ongoing bacteremia, we should have at least 2 positive blood culture for the microorganism as we described, that is we call as typically causing infective endocarditis. And this should also be evidence of endomyocardial involvement documented by echocardiography, or if there is development of a new murmur. Now, what happens is that if a patient has a previous underlying valvular lesion and he has certain, say, characters of a murmur, this murmur either becomes, say, decreased in intensity, or sometimes it may become more prominent, and sometimes it may change. Sometimes the murmur is audible and at other times it is not audible. So if there is this kind of a behavior in say patient who is having a previously known murmur, you should suspect that something has gone wrong with the valve, and it may be a development of say endocarditis. The minor criterias are that there should be predisposing factors, like patient may have an underlying lesion, patient may have undergone a procedure which predisposes to infection, like say dental procedures, like urinary catheterization, like say IV injections. Along with that, the patient may have fever, which is usually more than 38 degrees centigrade, or the patient may show evidence of embolization, like in one of our case scenario 3, where the patient was embolizing to both peripheral circulation and was having a embolization to the brain, causing stroke as well. Sometime since this all process of bacteremia followed by initiation of immunological process and recruitment of platelet, fibrin, and other inflammatory processes does lead on to immune complexes being immune system being activated, immune complex being formed, and these immune complexes then can start damaging other part of the circulatory system or other organs as well. They may involve kidney and cause glomerulonephritis, and patient may uh, be having symptomatic or obvious or overt hematuria, or maybe microscopic hematuria. And similarly, there are developments of, say, nodular tender nodules over the fingertips, which is called Osler nodes, or there may be vascular involvement in the small vessels in the retina in the form of frost spots. Then the patient may have positive blood culture, but it is not with the usual organisms. Similarly, patient may have an echo finding, but it may not be finding the major criteria, that there may not be vegetation, but there may be some valve damage being documented or demonstrated on echo. The diagnosis of infective endocarditis is seen. It is called a definite, say, endocarditis, uh, or at least you can have that this is a biggest sensitivity or specificity of around 80%, that when there are two major criteria being met, which mean a positive culture and an echo evidence of a vegetation or valve involvement, or patient have one major or three minor, or all the five minor criteria are fulfilled, then you can say that the patient is suffering from endocarditis. So clinical features of endocarditis usually are, as we said, majority of them present as subacute course and subacute bacterial endocarditis. So there are feature of infection, like there may be fever, they may be complaining of night sweats, they may have some weight loss, myalgia, they may have arthralgia, there may be palpable spleen, and of course the bacteremia causing all these symptoms. There may be cardiac features, that you find a new murmur developing as a result of a new damage to the valve, or a change of a murmur which was previously there. There may be already a known history of a patient being having a cardiac lesion, maybe a congenital lesion like VSD, or maybe patent ductus arteriosus, or patient have known to have a rheumatic valvular involvement of maybe mitral or aortic valve, and sometime uh, as a result of further damage to these valves and further incompetence adding on, and a fever and tachycardia, the underlying symptoms of heart failure may worsen, right? And this then again can be one of the presenting features. The patient who was stable previously with his known heart disease has decompensated or has becoming more and more dyspneic. It may be considered that he may not have developed endocarditis. There can be feature of embolization if it is the well left-sided endocarditis on the valve on the left side, like aortic or mitral. It would go to systemic circulation, causing maybe stroke, or maybe the damage to the peripheral vessels, or formation of a cold ischemic limb or a gangrene, or maybe go to the kidney and cause renal infarctions. But when it's the right side, it would go to the lung. The right-sided endocarditis, particularly in patients who are on IV drug abusers, or tricuspid valve involvement in the endocarditis process, there this vegetation would go to pulmonary circulation and can lead on to formation of a lung abscess or a pulmonary infarct, or may develop pneumonia, or maybe if it's a large one, it may cause a massive pulmonary embolism. The signs and symptoms of a patient having immune complexes circulating, or say showering into the system, can be in the form of Janeway spots. We'll just show you a picture. splinter hemorrhages, or development of hemorrhagic spots in the retina along with central clearing, which are called Ross spots. They may have tender nodule over the fingertips, which are Osler nodes. They may develop microscopic or overt hematuria, may also have features of joint pain or arthritis, and sometimes small petechial hemorrhages because of the capillary involvements. These are the two examples of Janeway spots. You can notice these flat-topped spots over the palm on the soles. These are called Janeway lesions. These are the classical splinter hemorrhages, which are linear dot-like, say reddish or brownish streaks seen on the, again, subungual tissues getting vascular or capillary involvement. These are the Osler's nodes, right? Tender digits, particularly the fingertips and palms. This is everted lower lid, and you may have subconjunctival hemorrhages. When you look at the fundus, the one shown on the center is the yellow one is the optic disc, but if you see about 1 or 2 disc diameter away on the temporal side, you would see a classical Ross spots, and of course there are multiple hemorrhages seen as well. Now, the clinical features of these patients who have acute endocarditis is usually a very high-grade fever. The acute endocarditis is more likely to get embolized early, and it would lead on to a very rapid and florid damage to the valves and a rapidly developing valvular regurgitation. And sometimes they may develop the surrounding myocardium, get involved into the infective process, and the formation of myocardial abscesses can be there. How do we investigate these individuals? Now, the investigations, primary key diagnostic investigation is culture. You have to document the patient is having bacteremia, right? And then we'll have to document that this bacteremia is possibly originating from certain damaged valve surfaces which are having vegetations. So the key to diagnosis is blood culture. It forms one of the major criterias, right? So at least 3 sets of samples should be taken 1 hour apart, and this should be done before we start antibiotic. The second, the most important, investigation is echocardiography. This is again a key investigation. Again, the echocardiography finding form major criteria to diagnose. And if you have positive blood culture for the organism that's already described, and you document that there are damaged valve with vegetations or formation of an abscess, or then you can consider it's definitely diagnostic of endocarditis. Sometimes this transthoracic echo cannot say visualize the vegetation very properly, particularly in the aortic valve situation, and sometimes it may be even in the valve, this mitral valve. So in these cases, we must do a esophageal echo. So transthoracic echo sensitivity is around 65%, whereas transesophageal echocardiography has a sensitivity of around 90% to diagnose, particularly aortic valve lesions and particularly the aortic root abscesses, which may not be very good visible or with the transthoracic echo alone. This is again what we have to look on echocardiography in infective endocarditis. We have to look for vegetations, we have to look for abscesses, we have to look for pseudoaneurysm. There sometimes may be even perforation of the interventricular septum, or perforation along the valve, say leaflets. There may be formation of fistula, even valve may develop aneurysmal type of a dilatation, and if there is a prosthetic valve, it may say dehiscence, or may show a paravalvular leak. So if there is a clinical in infective endocarditis, you go for transthoracic echo. If it is negative and clinical suspicion is still high, you go for transesophageal echo. Even in transesophageal echo, if it is positive, you might have to still go for a transesophageal echo. If quality is poor or prosthetic valve intracardiac device. So if initial transesophageal echo is negative, but there is still suspicion of infective endocarditis, you must repeat transesophageal echo around 7 to 10 days following the initial procedure. This is what is being shown as right, like this is this is apical fourth chamber view, and this is the left side of the heart, left ventricle. This is right ventricle already marked, and this is what we are talking about, vegetation over the anterior leaflet of the mitral valve. This is more in depth. This is how these vegetations would appear like dot-like spots over the valve surfaces, particularly toward the left atrial side. This is again an more say zoomed or enlarged focus. This is how these vegetations usually appear, small vegetations. This is parasternal long axis view of on echocardiogram on transthoracic echo. Here is our probe, and from here this is the right ventricle, this is the aorta, and this is the aortic valve. And look at it, this is the one cusp of the aortic valve, and this is the second cusp of the aortic valve, which is showing vegetations, right? This is the left atrium and the left ventricle. This again is showing some leakage along the valve from the aortic to the left ventricle. The two major investigations we already mentioned are a blood culture and an echocardiogram. You also have some supportive investigations like blood test. There may be increased ESR, there may be some increased in white cell count or leukocytosis. Inflammatory marker like C-reactive proteins may be elevated. Sometimes there may be say thrombocytopenia, and these patients may also have normocytic normochromic anemia. If you go for serological tests, since there is say recruitment of the immune system into it, the serum immunoglobulin may be increased, and same may be the total complement, and C3 may be decreased. In urine examination, you may find hematuria and proteinuria. ECG would be showing an underlying features of any chamber enlargement if there, or any arrhythmia if it is there, but it is ECG itself is not maybe diagnostic of. On chest X-ray, you may find evidence of cardiac failure in the form of maybe cardiomegaly, depending upon which valve is involved, and then there may be some concomitant involvement of the lung in the form of pneumonia or infection may be there. The complication which can happen as a result of this endocarditis is that the already damaged valve may further be damaged, and patient may develop cardiac failure. It may be formation of an abscess in the adjacent area, and this may extend to the myocardium, causing conduction disturbances, and the patient may develop new onset left bundle branch block or right bundle branch, or maybe conduction disturbances. There may be peripheral embolization, as we said. It may go to, particularly in post-MI status, it may go to brain or to cerebral infarction, may go to spleen or kidneys, causing and sometimes mycotic embolism involving the vessel wall, and may lead on to hemorrhage from those vessels, or they may present with intracerebral bleed or hemorrhage. And as we already mentioned, from the right side, these emboli may go to lung, causing lung abscess or further lung infarctions. So the main complications may be in the form of worsening or new onset heart failure, which is the most common complication. The most common reason for presentation of these individuals may be general ill health along with worsening of a previously stable heart failure. And this may be one indication for a surgical intervention in infective endocarditis patients. So uncontrolled infection like ongoing fever, ongoing leukocytosis, that can be a complication. perivalvular extension into the endocarditis and formation of abscess. And as we already mentioned, systemic embolism into brain, spleen, lung. And this sometimes may be the only symptom. They may present with stroke alone, they may present with subarachnoid or intracerebral hemorrhage alone, or maybe a gangrene of a foot alone. So neurological events, acute renal failure, sometimes joint pain may be the only features, and sometimes the new onset myocarditis and worsening again of heart failure will be the symptoms. How do we treat? We treat it according to the organisms which we suspect empirically, or which we develop, get an blood culture. Since in our part of the world, it is still Streptococcal viridans is the most common, and in a low cost or say economic combination still can be penicillin G or gentamicin, but more likely there are problems with this penicillin dosage, which has to be, as I said, 4 hourly or 4 weeks, and that's why that we have say newer antibiotic like ceftriaxone or vancomycin. So the dose of ceftriaxone is 2 gram intravenously once daily, and vancomycin can be given 50 milligram per kg every 12 hours, and duration of this has to be 4 weeks. If you're suspecting enterococci, you can think of either amoxicillin or gentamicin, or more so vancomycin still would be a good drug to give. Staph aureus usually again still responds to benzylpenicillin gentamicin, but sometimes you have to give it for a longer period, and maybe in a higher dosage. For penicillin resistant and methicillin sensitivity, cloxacillin and nefcillin combination is good, and penicillin and methicillin resistant, again the vancomycin and gentamicin. The treatment goal is to get rid of bacteremia first, right? Now, as we keep on saying that what is happening is that there is a damaged surface. On top of it, in damaged surface, there is colonization by bacteria. There is an addition of say fibrin and platelet, and which make it more say embedded, and then there is layer after layer of this. So this is what we say, that the bacteria are residing in some kind of a walled off or a fortified type of a say vegetation, and from there they keep on say showering these bacteria into circulation, and this is the continuous bacteremia. Now what we have to get is that it is not a simple bacteremia of other common infections. It is bacteremia which is continuously occurring. So to get rid of those bacteria, you need two things. You need an antibiotic which has a very high concentration of minimal inhibitory concentration in the circulation. That's why the dosage given are usually almost 3 to 4 times of what we use for common infection. The second thing is that this bacteremia is not a transitory like in common infection. So you have to give it for a very long period. Normally we treat infection for 5 days, 7 days, but here it has to be 4 to 6 weeks of a continuous antibiotic therapy in a high dosage. And not only in high dosage, it has to be very, very continuously being given. And to achieve this much of minimal inhibitory concentration for respective bacteria, you need this dosage to be given intravenously, or at least for an initial 2 weeks you must give it intravenously, may then be followed by oral, but majority of the authorities suggest that this antibiotic therapy for whole duration of treatment should be in the intravenous form. Of course, it becomes difficult for people to be staying in hospital for 4 weeks of antibiotic therapy, and that's why some authorities are recommending that for initial 2 weeks you give antibiotic intravenously, and then later on you can think of putting them on say oral. So apart from treating the bacteremia, you this bacteremia definitely should lead on to resolution of those vegetation. The vegetation may disappear, but if there is an ongoing valvular damage, then you must possibly have to have a surgery to avoid the complication or to correct the anatomy which has been further damaged by this process. So if your patient is having his own valve or native valve, the native valve endocarditis standard therapy is it usually takes 2 to 6 weeks to eradicate pathogen. But if it is prosthetic valve, it would take further longer to treat it. It may be 6 weeks. Similarly, when streptococcal infection, usually the 2 weeks of course can be used when combining with beta lactams and aminoglycosides. And of course, the most widely used drugs are amoxicillin and gentamicin. The surgery has a place in management of endocarditis. So particularly in regurgitant valve and when it is cause of a worsening or worst cause of acute heart failure, which is not responding to medical therapy, it becomes an indication for valve replacement. Or if there's an already prosthetic valve, again that valve may need to be replaced. If infection does not respond after 7 to 10 days of antibiotic therapy, sometimes fungal infections are very difficult to eradicate despite antifungal use, and these fungal infection mostly would require some surgical intervention. Gram-negative infections are again notorious, and they usually require a surgical intervention. If there is formation of myocardial abscess, it would not respond to just antibiotic therapy. It has to be drained, and it would be again requiring surgery. And some large fragile vegetations have a risk of embolization, and they again should be dealt surgically rather than just by medical management. And if someone is having recurrent infection, especially in infected prostatic valve, that also should be dealt with surgery. So there are plenty of reasons to go for surgical intervention in these patients. As I said, acute development of aortic regurgitation or mitral regurgitation along with symptoms of heart failure will be an indication for surgery. Annular or aortic root abscess is dealt with surgically. Fungal endocarditis and again persistent infection would be indication for surgery. In prostatic valve, all the indication as for native valve, but if prostatic valve endocarditis occurs within first 2 months, murmur is suggestive of valve dysfunction, there is severe heart failure, or there are conduction abnormalities on ECG in the form of complete heart block or new onset conduction defects, and if there is Staph aureus, all these are indication for a surgical intervention rather than just relying on antibiotic therapy. Since there is embolization, and embolization is both from the vegetation, so there would be a question of that whether these patients should be anticoagulated or not. So the consensus is that they should not be put on anticoagulants, and those patients of prostatic valve say those have prostatic valve and they are on anticoagulant, particularly those with metallic ones, during the septic phase you probably have to discontinue their anticoagulation for a short while. Sometime I mean the mainstay of this endocarditis treatment may be that it should not happen again, or it should not happen in the first place. So all those procedures which are likely to cause bacteremia should be covered with say antibiotic course injection of or an oral antibiotic just 1 hour before the procedure which is to be done. So these are the various procedures where you probably have to think of giving a initial antibiotic say regime just 1 hour before the procedures. The common regimes, if patient is oral and is having penicillin allergy, then you can think of giving clindamycin, cephaloxime, or azithromycin. But usually either one of this is given 2 gram 1 hour before the procedures. And if it is clindamycin, it has to be 600 milligram 1 hour before the procedures, or azithromycin 500 milligram before the procedures. Injectable parenteral, you can give ampicillin 2 gram IV 30 minutes before the procedures, or clindamycin 60 milligram IV before the procedure. This is the, say, prophylaxis against endocarditis in someone who possibly has an underlying cardiac lesion and has to undergo some procedures. High risk patient, you can give ampicillin gentamicin. Penicinergic, you can give vancomycin plus gentamicin. If there is moderate risk patient, you can rely on amoxicillin and penicillin, and penicinergic, it would be vancomycin. The prognosis, disease has significant morbidity and mortality, and prompt diagnosis and treatment essential to minimize mortality. Without treatment is 100%. So it's quite deadly disease. Mortality is 20 to 30% with complications, like if someone develops acute endocarditis with cardiac failure, or he has developed infection of the prostatic valve, or microorganism resistant to therapy. I hope many of you might have seen this place. You may take it as one of your assignment, that who recognizes this place, which is from Pakistan. Thank you very much for your patient listening, and will inshallah will be sending you the assignment based on